Hey everybody, so today we're going to talk about Hallux Valgus and Hallux Rigidus, which I'm going. So first thing to know about Hallux Valgus is it's a complex deformity. You get lateral deviation in the great toe with medial deviation in the first metatarsal. It's more common in women. 70% of patients with Hallux Valgus have a family history. So yes, you can blame your parents if it happened. And generally, we kind of split this into really two types. There's an adult type, and then there's an adolescent and a juvenile type. The adult type is more of a degenerative change that happens over time. And the adolescent and the juvenile type is one that kind of occurs due to the deformity that was naturally there as they grew up, which makes sense. It's similar to a lot of other pathologies we talk about. So the risk factors for this, there is a genetic predisposition. Ligamentous laxity, convex metatarsal head, pes planus, rheumatoid arthritis, cerebral palsy. Those are all intrinsic factors. Extrinsic factors, a little more controversial, but shoes with a high heel, shoes with a narrow toe box, and of course upsetting the universe. You don't want to do that because you don't want a bunion. So the pathoanatomy that exists, so this is a valgus deviation that promotes varus position of the metatarsal. The sesamoid complex becomes lateral to the metatarsal head, which then moves medial. The medial capsule, the joint capsule becomes stretched and attenuated. The lateral capsule becomes contracted. The adductor tendon becomes a deforming force. It inserts on the fibular sesamoid, and so we'll pull it in that direction. You get a lateral deviation of the EHL. The plantar and lateral migration of the adductor hallucis causes the muscle to plantar flex and pronate. And then the windlass mechanism is going to become less effective, which can lead to transfer metatarsalgia. Again, here you can see the insertions of the adductor as well as the sesamoids. And then this cross-sectional view right here really shows that pronation as it happens, as those sesamoids start to deviate laterally. They will erode away that cristae on the bottom of the metatarsal. You get that lateral deviation of the adductor, the medial deviation of the extensor, and these will all kind of pull everything into this combination and become a deforming force. So the most common presenting factor is difficulty with shoe wear due to that medial eminence. And people get pain over that prominence about 70% of the time. There's cosmetic concerns is listed here as 60%. It's probably higher. We all know it's probably higher. Pain underneath the second metatarsal head can be common as well due to that transfer metatarsalgia. And compression of the digital nerve, especially that dorsomedial nerve in between that now prominent medial eminence and shoe wear, can be a big factor as well. So the hallux really rests in valgus and pronated to the deforming force, and you'll see this on physical exam, the first part, which is always inspection. And you want to examine the entire first ray for its range of motion, for first ray mobility, and you want to evaluate any associated deformities like pes planus or lesser toe deformities, as well as midfoot and hindfoot conditions, corns, calluses, things that are going to cloud the picture and maybe can be causes of pain and even bigger sources of pain. And you want to look for generalized ligamentous laxity because that might affect your treatment choices. You also want to look at how the great toe is sitting relative to the floor. Is it pronated? Is it up? Is it down? Is it above that second toe? Is it under that second toe? And certainly, as you might imagine, this person might not be having pain at their bunion and at their hallux valgus. They might be having pain over the top of their second toe. But clearly, you're not going to be able to treat that hammer toe unless you get that big toe out of the way. And so you really want to take a good exam at their entire foot and make sure that you see them standing so you're seeing how that foot is living when it is on the ground. When you get radiographs, this is a standard series which should include weight-bearing AP and lateral. The sesamoid view can be helpful to kind of see how they're pronated. Some people these days even get weight-bearing CT scans to kind of evaluate the sesamoid complex to kind of see how rotated the first metatarsal is. And radiographic parameters still guide treatment. We've been doing it for a long time, and it is still really helpful. And by guiding treatment, I really mean surgical treatment. Displacement of the sesamoids is important to note. Joint congruency, very crucial to note if you're able. That can be a little difficult at times, admittedly. And you want to look for evidence of arthritis. because that really will change what you do and why you do it. So the radiographic parameters that we use are really typically 3.5. We're going to give the proximal phalangeal articular angle kind of a half quote here. So the first one that we look at is really the Hallux Valgus angle, and this is the measurement between kind of the long axis of the proximal phalanx and the long axis of the first metatarsal. And so, this one is relatively easy to measure. The bigger the angle means, the more deviation that you have. The one that we probably use more commonly in our decision making, however, is the intermetatarsal angle. And this is down the long axis of the first metatarsal, down the long axis of the second metatarsal, and then the angle that forms between them. And normal is 9 or less than 9. Anything over that is considered to be abnormal. And then also important to look at is what is called the distal metatarsal articular angle. Really what you're trying to look for here is what is the joint relative to the long axis of the first metatarsal. And so what this means, if you have a larger distal metatarsal angle, it means that that joint is deviated more laterally relative to the long axis than is normal. And normal is less than 10. Please note here that a little bit of valgus in this joint is actually normal. So a slight bit of valgus is normal. It's when it becomes excessive that it becomes problematic. So a perfectly straight toe right here actually would be abnormal. And so you got to factor that in when you're making corrections and things like that, and especially for fusions later on. So why do we make a big deal about it? Well, we make a big deal about it because we do want to know, is this deformity congruent or non-congruent? This makes a huge difference in what you do treatment-wise. So a congruent deformity, which here is on the right, this is typically what we see with juveniles or adolescents, to where it's really how the joint formed and its deviation, kind of its natural deviation towards that second metatarsal, that's really the cause of the problem, as opposed to what we see in A, which is more of that pathoanatomy degenerative type process where everything has started to contract on the lateral side and become attenuated on the medial side, and the toe has pronated. That's more the case in A, where you get these non-congruent deformities, these degenerative type processes where the joint surface of the proximal phalanx has left and subluxated off of the joint surface of the distal metatarsal. And that really changes what you do in terms of treatment, as we'll get into in a little bit. So in terms of classification, it's not a hard and fast classification, but in general, we normal an HVA less than 15, an IM less than 9, and a congruent joint. And then for mild, an HVA 15 to 20, an IM 9 to 11, moderate HVA 20 to 40, IM 11 to 18, and then severe greater than 40, greater than 18, and then an incongruent joint. So for almost everyone, you really want to think about conservative management to start. And this means shoe modification, because we talked about shoe wear is a big issue. It's our first line of treatment. Exercise, activity adjustments, orthoses are more helpful in patients with pes planus or metatarsalgia. So when talking about in-shoe orthotics. And then when we talk about surgical options, in general, the indications are when conservative treatments have failed. And I would warn everyone to not perform these for cosmetic reasons alone. Those people will be unhappy with a lot of things. This is an imperfect surgery, and it's possible to make a bad toe into a good toe, but it's really hard to make a good toe into a great toe. And so I warn all my patients about that. There's more than 130 operations, and as with a lot of things, there isn't consensus because there hasn't been the data to back up one thing being that much better than the others. There's a number of soft tissue procedures, distal procedures, proximal, fusions, and MTP. The general rule here, soft tissue procedures are indicated in very mild disease in young women. It's almost never done. I'm trying to think if I've ever actually done one in isolation. I'm not sure that I have. The distal osteotomies indicated in mild disease. The proximal osteotomies or the combined osteotomies in more moderate disease. Fusion procedures, meaning fusion of the metatarsophalangeal joint, is indicated in severe disease with arthritis or in people who are syndromic or have extreme ligamentous laxity. MTP resection arthroplasty, also known as a Keller arthroplasty, is really only indicated in elderly patients with a very low functional demand or people who have osteomyelitis or something else to where you really need a resection. So that is almost never the answer, and really almost never the test answer. This just kind of shows you where the number of and the type of procedures and kind of where they're done. The achinosteotomy is one that's done if you have Hallux Valgus interphalangeus, to where it's actually you get a lateral deviation of the proximal phalanx and you can bring that back. For the distal osteotomy, which is most commonly a chevron type osteotomy, it's the most commonly done. Again, for that mild disease. The kind of the moderate disease is where you're going to find the most variability, and that's where you can kind of get into these more proximal osteotomies or the first metatarsophalangeal joint fusion, which is also known as a lapidus. These proximal osteotomies are usually combined with a more distal soft tissue procedure, as we'll go over in a little bit. And so that soft tissue procedure, the modified McBride, what's the modified portion of it? Well, we'll get into that. And so usually, this is for very, very mild disease, no degenerative changes. It's almost never done in isolation anymore. Usually we do it in combination with one of the other things, more typically the proximal osteotomies, to get that kind of distal correction, in addition. So here you can kind of see how it's done, removing that medial eminence. You're going to plicate and bring down the medial structures. You're going to lengthen the lateral structures to try and get it back. And then for more mild disease, most commonly done is this distal metatarsal osteotomy, also known as a chevron. It's called a chevron due to the shape, that kind of V shape, like chevrons on a sergeant's uniform. And you just translate. Literally, you make the cut and you translate it laterally. The nice part about this is that it is a very stable osteotomy and has a very high healing potential. The reason we only do it for more mild disease is that you can only shift it so far, about 50% over. And so the biggest problem that people run into is trying to kind of game the system a little bit and get more correction out of this than really is possible. And then you can run into problems. So the most common complication is actually recurrence after using this, because it was used for a procedure that was a little too, or I should say used for a pathology that was a little too big to truly correct it. But for more minor pathologies, this can be a really good operation. It has a high healing rate. It's stable. You can use almost anything for fixation and it will usually work. There is a complication of avascular necrosis for kind of any of these distal osteotomies. And so for a lot of times we won't do a soft tissue procedure on the lateral side in addition to this, because we worry that if we make a lot of soft tissue stretching procedures along the distal head, you may get AVN of the distal head, and that's a bad day for everyone if that happens. The proximal osteotomies, again, there are a number of them. Myself, I do the crescentric, so does Dr. Olson. Dr. Chen, I know, has done the scarf a decent number of times. But the whole point of the proximal versus the proximal osteotomies are more powerful. And so with a smaller shift, because it's more proximal, you can affect a larger change in the angle distally. So these are indicated for moderate and severe deformities. They have high corrective power. And they're almost always, as we talked about, accompanied by a distal soft tissue release. And they all have kind of their pluses and minuses between which one you use. And so usually it's a matter of surgeon choice. The double osteotomy, this is one that is done, as you can see here, and I think this illustrates it very well. Thank you, Dr. Coughlin. Of a juvenile bunion here with a high DMMA. And so this is a congruent bunion that really the deformity is along the distal metatarsal, And it's not so much that the metatarsal has fallen off of the joint, but that the joint itself is actually improperly angled. And so in order to correct this, you can see here making a double osteotomy. So not only do you make the proximal osteotomy, if you just made the proximal osteotomy and shifted so the IM angle was reduced, it would actually make things worse. And so you have to correct the overall angle of the distal joint as well. What about just actually fusing that joint? And I would argue, and I'll argue, I think successfully, that a first MTP fusion is the most reliable bunion surgery. And what I mean by that, lowest recurrence rate, probably highest rate of pain relief, patient satisfaction plus minus. But really good operation. You can correct, as you see here, you can really correct that valgus. You usually do not need to add on a metatarsal osteotomy in addition, believe it or not, and it is true. And you can resect that medial lemon so it's not as prominent. There will be kind of, in a weird way, as you shift everything over, the mechanisms of everything will pull the first metatarsal back a little bit, and so it's it does have some reduction of the IM angle even when you do this. So you want to think about this really for anyone who's got severe degenerative changes and a bunion. Fusion is definitely the best answer. But also for other people who have a cerebral palsy or Downs who are just very ligamentously lax, because our other procedures just have a really high rate of recurrence. Also for rheumatoid arthritis, where their capsular integrity can be really compromised, or they're highly likely to develop arthritis later on, people with gout or other inflammatory diseases, Ehlers-Danlos, and people certainly who have recurrence. So if they've failed the other procedures and it's come back, certainly a fusion is a reasonable option. When you perform the fusion, it's usually done at about 15 to 20 degrees of valgus. Again, remember that the HVA is 15 degrees or less, and so you usually want to put it in about 15, sometimes less, and it becomes a little bit of a judgment call on your part, kind of based on what the shape of the foot is. But the point is, you do want to give it a little bit of valgus. Perfectly straight is not the answer. And usually 30 degrees of dorsiflexion relative to the metatarsal shaft, or what I would argue is more important, is 10 degrees relative to the floor. As you might imagine, the metatarsal shaft, if you have a more cavus foot or a more flat foot, that angle between the metatarsal and the first the proximal phalanx will change. And so you always want to see kind of what it looks like relative to the ground. So I encourage everyone to get a flat plate in there. I like to make sure I can get my pinky underneath there, that it's slightly elevated. And so as they walk, they'll be able to roll off their foot a little bit. The Lapidus procedure, which is a first metatarsal phalangeal joint arthrodesis, this is really done for, again, severe deformity. It's done for hypermobility of the first tarsal metatarsal joint, or really it can be done just for moderate to severe bunions as well. And again, this is a first MTP arthrodesis. Actually, the traditional Lapidus was a first tarsometatarsal joint arthrodesis, as well as an arthrodesis between the base of the second metatarsal and the medial cuneiform. That's the traditional Lapidus, and that's certainly reasonable. And then it's usually accompanied with a distal soft tissue procedure, again, to kind of realign the sesamoids, get everything back underneath, and restore that anatomy distally. The Keller, the section arthroplasty, we almost never do it. It's really more of a tradition at that time, or for people that just have osteomyelitis or other extreme infections or other things that are more problematic. In terms of complications of surgery, each surgery has a couple of unique complications, but recurrence certainly does happen. It's the most common cause of failure is really insufficient preoperative assessment and failure to follow the indications. So when we talked about why so many of the distal chevrons fail, it's really because it was done for bunions that were a little too severe for that particular operation. Recurrence is more common in juvenile and adolescents. I think for some of this, it's because people fail to recognize that they need to make the double osteotomy and really get that joint back. You know, a non-compliant patient certainly is up there, but really you never want to blame your patients for what happened. You always want to make sure that, you know, sometimes what they do is out of your control. So you really want to make sure that you're doing everything you can to get them there on the other side. AVN, you know, does happen, especially in those distal osteotomies. The medial capsulotomy, you know, will provide an insult in this. So if you do the lateral capsulotomy at the same time, that can be problematic. So it's most problematic with the distal chevron, but can happen with other distal osteotomies as well. Dorsal malunion with transfer metatarsalgia. This is associated with a lapidus or really any of the proximal osteotomies. And so if that first metatarsal is elevated a little bit, what happens is the stresses get moved over to the second metatarsal head, and people can get pain there. Sometimes even with a good, or what seems like a good bunion correction, things can shift over there as well. And any of the shortening osteotomies can be problematic. When this does happen, usually, and it's unrelenting for pain and metatarsal pads and other things, then a shortening metatarsal osteotomy, a Weil osteotomy, or other osteotomy is a reasonable thing. You also might be worried for cock-up deformity. This is usually due to some injury of the FHL if it gets cut. And this is a severe complication of the Keller resection. So usually if you resect that metatarsal head, that first array will kind of cock up. The extensor will become kind of contracted. The flexor will contract and it'll cock up. And that can be actually quite painful. Neuropraxia can happen too, especially for the dorsomedial cutaneous branch of that nerve right along the medial side. And so you really want to look out for that as best you can. Make sure that you're not sewing it in or injuring it on your initial approaches. Hallux Valgus is the most commonly iatrogenic, and so that's the most common cause. It can happen otherwise. So varus is when you kind of tip over the other direction, and this most commonly happens due to an overcorrection. What you can see here on this picture on the right is that toe just looks straight. And this is really, what I was trying to emphasize, is that a little bit of valgus is actually normal, and a perfectly straight toe, as you're seeing here on the right down that metatarsal shaft, is actually an overly straight toe. So an overcorrection of the IM angle can happen, excessive lateral capsular release, and overresection of that the medial side of the first metatarsal head to where it can just kind of slip over that side, and what is now the modified McBride. The original McBride used to do a fibular sesamoidectomy, and the fibular sesamoid was just removed. We do not do that anymore because it was found that removing that really removed a large portion of the capsule on that side with it, and a lot of these people went into varus as a result, and so we leave that fibular sesamoid right where it is. So what's the difference between juvenile and adolescent versus adult? Well, it's often bilateral and familial. The pain is usually not their primary complaint. It's often cosmetic. Because a lot of these people, the joint is actually working just fine. And so it just looks a little bit weird. I'm not saying these people can't be painful, because they certainly can be. But oftentimes, it's really more about how it looks, because the joint hasn't shifted or moved. The joint mechanics are working okay. And so these people tend to not have as much pain as when you get the degenerative process later on. The DMMA is usually increased, and it can often be associated with a flexible flat foot. And recurrence is really the most common complication in Hallux Valgus, and these can be a little bit hard to get your double osteotomy correct, but it is important to kind of recognize that this is a unique variant and should be kind of approached that way. Again, shoe modification is the first thing you can do, and it's helpful. And in terms of correction, really it's best to wait until skeletal maturity if you're able to do it. You often you could do a medial cuneiform osteotomy, and surgery is indicated in symptomatic patients, and severe deformity, so a DMMA greater than 20, and really you should really think about it. And anyone who has a juvenile, and make sure you're not fooling yourself, should really consider performing a double metatarsal osteotomy. All right, so in our remaining few minutes here, we're going to talk about Hallux rigidus and joint disease of that first metatarsal. So Hallux rigidus is, again, one of these kind of terrible terms, but one that is stuck down throughout the ages. So, it's characterized by loss of motion of the first MTP joint, but really it's just degenerative arthritis of that joint, and we call it Hallux rigidus because, tradition, and we've never gotten ourselves away from it, which I wish we would. But like any joint arthritis, you get osteophyte formation, which can lead to dorsal impingement just due to how the joint is situated. The arthritis of this joint tends to affect the dorsal aspect of the distal phalanx and the articular cartilage there more so than the plantar, though it can affect all of it over time. So acute trauma and repetitive microtrauma are thought to predispose to arthritic changes. Anatomic variations certainly play a part. It does seem to potentially go in families. When you talk to a lot of these people who have arthritis, they won't remember a specific trauma, fractures, sprains, things like that, but likely there was that to begin with. Classification scheme, is similar to other arthritic classification schemes. I don't know that there is much value in memorizing what's considered a grade 0 or a grade 4, except unless you're doing research papers. But it is a good idea to understand kind of what's mild, what's moderate, and what's severe, and how you would treat them. So these people typically will have first MTP pain and swelling, especially with dorsiflexion. They can get shoe irritation because as they build osteophytes along that top, they will rub on shoes. And the pain sometimes can become less severe as the disease progresses, which is a little bit weird, but people can kind of start to autofuse. That is not always the case. Sometimes the pain can become more severe too. And so it's a little bit interesting in that regard, and that sometimes it can dissipate. Most of the time it actually does get worse. On physical exam, people have limited dorsiflexion and they'll have pain with the grind test. Grind test is where you're actually loading the joint to kind of see, really what you're trying to see is when you dorsiflex the joint, is the pain mostly there, or as you grind it, do they have pain in the center? And that really helps maybe to tell you where the most location of the pain and arthritis is. X-rays, definitely good to get. You want to look for osteophytes. You want to look for joint space narrowing. And you want to look for subchondral sclerosis and cysts. First line treatment is generally non-operative. And so, stiffer shoes, things like Hokas, Danskos, Birkenstocks, things that don't have a lot of flexion through the toes can be really helpful for these people. Also, inserts can be really helpful here as well. And so a Morton's extension, or what I like to use, which is just a carbon fiber spring plate that gets all the toes, can be really helpful. And then stiff shoes, and sometimes even just stretching out the shoes, with a shoe stretcher or something over the area where the osteophytes are rubbing on the shoes, can be really quite helpful. Joint debridements and synovectomies, patients with an osteochondral defect or really acute disease, that can be helpful. Dorsal chelectomy we really do for mild to moderate disease. And what a chelectomy is just a resection of the dorsal osteophyte, and oftentimes even up to 25% of the top of the joint, because that is the part that is most severely affected with these diseases. The problem with this, of course, is you're not really changing the overall course of the disease, and you're certainly not treating the entire joint. And so it is possible that after you're done here, people might still have pain. This is quite good for people who have really mainly dorsiflexion disease. They have a negative grind test, they have a lot of pain with dorsiflexion, or people who really just have pain from rubbing on those large bone spurs on the top, and this can be a really good choice. When people have really extensive arthritis and they have pain in the mid-range of the joint during passive motion, you really worry that this is not going to be an effective treatment for them and not last that long. So here it is, you can see kind of the removal of the top of the joint. You can see with this saw, kind of removing just the very top of the joint where it's a little bit diseased. The Moberg procedure is one that is still done, is not done that often. And what this is it's a dorsal closing wedge osteotomy of the either the proximal phalanx or the distal metatarsal. And so people who really have reduced dorsiflexion, meaning that they cannot get their toe up, and the chylectomy does not give them enough motion, you can actually flip the toe up a little bit to give them a little bit more motion. This was popular for a while. It has issues, as you might imagine, as with anything. You can go too far, and so people can be cocked up a little more and unable to get their toe fully down on the ground, which people don't like. People can continue to have pain if they still have areas of the joint that are arthritic, and so it's not one that we do often. We did talk about the Keller. Again, this is good for only for really minimally active people or people who have, in addition to having arthritis, have infection or something else that would prevent some of these other procedures. MTP arthroplasty, still a believer that at some point we're going to get this right, and this is going to become something we do more and more, just like total ankles have become. But at this point, it's not quite there. There's a number of different ones out there. So there are kind of soft tissue interpositional arthroplasties that are done where you can kind of make a cartilage cap or a kind of a anchovy or other things that you can put in the joint to try and provide some space. They work kind of okay. They're good for people who really have severe disease but really want to preserve motion if possible. Silicone implants were the original joint replacement in this joint, and for some people they work great. For other people, they are a total disaster. You can get really extensive osteolysis and synovitis, which can cause mid to long-term pain and joint destruction. And the problem in that case is you also have a ton of bone loss when that happens. In addition, kind of more recently, the Cartiva has come out, and we've had talks on Wednesdays about that. And the Cartiva had really good results in their kind of industry-driven studies, and they just haven't quite been able to be replicated. The Cartiva, and I'm sorry I don't have a picture here, is a kind of a hydrogel semi-cap that's just placed into the distal metatarsal, and it has kind of mixed results. The original results from the industry studies were about 90% good results. Most of us say our results are kind of closer to maybe 75, maybe 80 at the best, with a decent number of people that still have pain. So unfortunately, it's a really easy technique. It seems to, look good initially, but the results are not as good, I think, as any of us really hoped they were, unfortunately. The nice part about the Cartiva, I will say, is that if it fails, you did not take away a lot of bone, and that allows us to get to what is probably the most reliable procedure for people with severe arthritis, which is a joint arthrodesis. So the indications for this are grade 3 and 4 disease, significant joint arthritis. It has a really high fusion rate, probably better than 90% with the custom plates and the locking plates that we use these days. The one big complication that can happen is people can get degeneration of their interphalangeal joint. It is usually asymptomatic, and so people can get some changes radiographically without it being necessarily terribly painful. But it has a very high fusion rate. Getting the position right, as we talked about, earlier in the talk, I think is really crucial. And so, but is a really good, is the most reliable. And so, no one likes the F word, as people say, but a fusion is a good procedure. And so I tell most of my patients, and of course not everyone's happy, but I tell most of my patients that the toughest thing I do is convincing someone to get a fusion, because after that, things usually work out pretty well. So in summary, thank you guys for coming on this journey with me. For mild disease, you want distal things, distal osteotomies for mild hallux valgus. So you're going to do a distal chevron. For moderate to severe, you want either a proximal osteotomy or a fusion, meaning a lapidus. For a congruent joint, aka juvenile, most likely a high DMMA, then you need a double osteotomy. And for hypermobility, you really want to think about a TMT fusion, meaning a lapidus, for hypermobility without something like Ehlers-Danlos or Down syndrome or some of those other hypermobility things. For those, then you want a first MTP fusion. And then when it comes to first MTP, J arthritis, in terms of the test answer is probably fusion still, not replacement for severe, and a chylectomy for less severe. All right, so thank you guys. I apologize that I was not able to be there virtually today, but hopefully this helped out. And please, if anyone has any questions, please reach out. I know this can be a little bit confusing. I want to make sure that everyone has an understanding and a basis to build on. All right, thank you very much.